Welcome everyone to our 12th annual PIPC Forum. We're so glad to be doing this another year. I can't say that I agree with Tony Moore. It's just been like time flies. I can't believe it's already our 12th year. My name is Sara van Geertruyden, and I serve as the Executive Director of the Partnership to Improve Patient Care, also fondly known as PIPC. When PIPC started in 2008, our goal was to foster comparative clinical effectiveness research so that people with lived experience were participating at every stage of research. And today you heard from Caitlin McCormick over at PCORI about the great work that they're doing around the science of patient engagement, which is so important. And now they're also looking at how they collect data, including economic data, which we're also really excited about. Like her, I hope you will take a look at their research priorities as they come up and comment. I know that we plan to do so as well. But during our discussion too today, we want to focus on the National Council on Disabilities efforts to raise awareness of the use of quality adjusted life years and discriminatory metrics and value assessment, and what that really means for people who are trying to get the care that they need. In the email that you received with the link to this event, you'll find bios for all of our participants today. So I'm going to be providing, sort of a short snippet of their bio. And you also will get you got some background information about the methodological flaws of metrics like quality adjusted life years, just some background information to better understand what those metrics are and how they inherently discriminate by devaluing the lives of people with disabilities, chronic conditions, and older adults. But without further delay, I would love to introduce now our first panel. So that we can get their perspectives as representatives of patients and people with disabilities. And so first I'm going to introduce Meghan Moyer. Meghan is Disability Rights Oregon's Public Policy Director. She leads the organization's efforts to promote the civil and human rights of people with disabilities and people with mental health conditions through legislation and policy advocacy. Over this last year, I've had the opportunity to follow how effective Meghan has been in her work in Oregon with the legislature and with the Oregon health system, which you're going to hear a lot about today. We also have Jenn McNary with us today. She's a trusted voice in the rare disease community and the mother of sons with Duchenne. She's a public speaker and a fierce advocate. We have all witnessed that. She organized the largest FDA advisory committee hearing in history with over 1,000 Duchenne advocates, families, clinicians, and researchers in attendance. And for all you patient groups, you know what a big deal that is. Currently, Jenn is the head of patient advocacy and engagement at Fulcrum Therapeutics and is consulting in the biotechnology space as an expert in caregiver and patient engagement. So we're really excited to have Jenn here today as well. So Meghan and Jenn, you can take yourselves off of mute, and I'm going to sort of just dive right in with an introductory question. And if I missed anything in your introductions, feel free to add some flavor to that. But I want you to tell us a little bit about your real life experiences with QALYs and the states where you live, and what that has meant in terms of coverage, access to care, that kind of thing. So Meghan, maybe we could start with you, and then Jenn will move to you.
Sure. Oregon has for 30 years operated our Medicaid program under an 1115 waiver, which allowed us to design our own approach to our Medicaid population. And in many ways, it was innovative and cutting edge. One of the ways was that Oregon has strived for 3 decades to cover more people than what the federal government requires. We have always valued children having access to care, people who are low income but have not traditionally been able to qualify, people with disabilities. So there are things that about Oregon that are really great and strong when it comes to how we've operated our Medicaid programs. Unfortunately, in order to get waivers, you have to show that it is less expensive for the federal government to grant your waiver than if they were to just fund a traditional Medicaid program. And the way that Oregon accomplished that was that they made a policy decision 30 years ago that we would cover more people, but we would offer less care. And those are really hard decisions. And there are pluses and minuses to both approaches. Oregon has always valued preventative care and done a very good job of covering preventative care in a broader sense than Medicaid does historically. But when it looked at how it was going to prioritize what it was going to cover and not cover, Oregon implemented what we call the prioritized list. And in order to compare apples to oranges, Oregon needed a metric to score conditions and their treatments and then rank them. And here's where QALY came in. Even though originally Oregon said, hey, we're going to use QALY, we'll use this score, we'll figure out what we can afford, and then we'll have a cutoff. The federal government, when we originally applied 30 years ago for our waiver, said, no, you can't use QALY, that's discriminatory and it violates the ADA. So what Oregon did was it said, okay, we're going to make our own scoring formula, but they use QALY in that formula. So as it created a score, it ranked different things, and one of the multipliers was the QALY score. And what that resulted in is that Oregon has a list, and right now we cover the top 471 diagnoses on this list get coverage, and anything below number 471 that we do not treat. So if you have a condition that falls on number 472, there is no treatment at all for you. And unfortunately, there's also no appeal process because it is cut and dry. We either cover it or we don't. The fact that we've approached it that way and our scoring is biased against people with disabilities, that's resulted in people with disabilities here in Oregon disproportionately not having their conditions covered. And so that impact has been huge. There have been many instances where families have been fighting in the Oregon legislature and other places because they simply could not get access to care that, if they had private insurance, would be covered. So that's kind of Oregon's background with how QALY impacts our care.
So we're going to come back to this. The whole idea that you don't have an appeals process is a bit appalling to me. Jenn, I want to give you a chance too, though, to just provide some background on the work that you've been doing and what you see in Massachusetts.
Sure. Firstly, I have to say that I'm speaking on behalf of myself and my family. We left that piece out, but although I do work in biotech and held a number of volunteer positions, I'm speaking about my children and my experiences. And also, Meghan, I wish I had known you when I was advocating for a family in Oregon for coverage for a Duchenne drug, but I'm happy to know about the work that you're doing. In Massachusetts, we have this unique situation where we are in an innovator state. This is where most of the biotech companies exist, and we really support innovation in theory. But unfortunately, what I've seen time and again in Massachusetts in practice, all of our patients who have a life-limiting condition, like my two sons, Austin and Max, have Mass Health, Mass Medicaid coverage. And even my 14-year-old son, who has immune deficiency, qualifies for Mass Health coverage. Unfortunately, they are utilizing many different ways to deny or decline new innovative medications that often come right out of companies that are in Massachusetts. And my personal experience is that my son, Max, was in a clinical trial where the actual literal accelerated approval came as a result of, in part, his muscle biopsies. So we knew that this drug specifically worked for this specific kid. And so no amount of data was at play here. The FDA deemed this drug appropriate for use in this patient population, but yet we experienced multiple denials based on the fact that Max had stopped walking since getting out of the clinical trial. And so Massachusetts was utilizing, prior to any kind of written in stone policies, they were utilizing just that cutoff, that arbitrary cutoff, as once a patient stops walking, they no longer deserve a treatment that might preserve the rest of their function. Now, for reference, he stopped walking a lot later than most people do who have Duchenne. The drug was working, it was slowing progression. But when it came to Mass Health, even with multiple appeals, the pharmacist and the nurse that were sitting in the meeting of the appeals with myself, my son, our doctor, our lawyer, were saying that according to reports, there is no value. They did not name the ICER report, but according to reports about Duchenne and about these drugs, there is no value, zero value, even with a therapeutic that cost nothing, unless this could make my son walk again. And so, you can imagine them then saying in the next breath that these practices are not discriminatory, because that is the very description. This is the definition of discriminatory, saying that now that your son cannot walk, we will not cover it. And the sad part about this is, even though they consider having a positive policy, they do cover Exondys, they do cover steroids, they do cover a number of therapeutics for Duchenne in Massachusetts. If you have Mass Health, as soon as you stop walking, you're no longer covered. And so you then become devalued as a human being. So it's incredibly enraging. It's a policy that is very much discriminatory against patients.
And so you were not able to get any insight as to what, like, specifically, because this is one of the things that comes up, I know, in a lot of our conversations, where states will make comments like that, but we don't know. We assume they're using an ICER report, right? But the level of transparency in terms of the evidence that's sort of underlying a lot of these decisions, I can just tell you, I've struggled to understand, even when I want to glean, okay, what exactly is it that a state, I'm like, I can't find it. So is that essentially where you are in Massachusetts?
So, and I say this really about every state, but Massachusetts being the place that I live, that is a problem. The practices and the way that these drugs are evaluated, that these decisions are being made, are not transparent. They don't tell you where they're getting their information. It is seemingly arbitrary. And so saying that this doesn't benefit a certain patient population, when the label that the FDA provides for an approved therapeutic really should be what's followed. And, the other piece is that, and I know we're going to talk about this later, but, organizations that give that give recommendations to the pharmacy and therapeutics, or the DUR committees, they don't really see the downstream effect of saying that there isn't value to this therapeutic. They're kind of stuck in that scientific box, much like Meghan was describing, where people think they've come up with a system and a formulation that works. Downstream, what they're saying is that, this arbitrary decision is being made. There's no transparency. So how can a patient advocate for a change if they don't know why these decisions are being made? And we were lucky enough that we found other methods of coverage, free drug programs and other, but for those patients who were never in a clinical trial and are just diagnosed today and are non-ambulant, they will never receive access.
Wow. Okay. So Meghan, I'm just thinking about the 1115 waiver process that you're going through then with the renewal coming up. What are the primary asks then that are coming from the disability community in light of, the inability to appeal to me just seems like such a.
We have two asks that we are working on through our waiver application. One is that we want Oregon to not be allowed to look at quality at all in our decision-making process. Like Jen said, there is a level of ambiguity about in what ways these scores are used. We have gone back and forth with our, what we call the Oregon Health Authority. They run our Medicaid program, about how they use them, when they use them, are they still using them? And that is very gray. They certainly use quality when they originally scored everything, and they are open about that. Now they're a little bit like, well, we don't base our score on quality, but we don't want to not be allowed to look at quality. Trying to understand, did you go back and rescore everything? No, they did not go back and rescore everything. Why, if you don't use QALY, then why would you want to be able to look at QALY? Does it influence staff recommendation, that type of stuff. So we also have this level of exactly what are you doing? How is it being used? There's also some other scoring that happens that isn't necessarily ICER's QALY score, but also really kind of looks at quality of life type metrics. So what we want to do is we want to start by saying, please do not use any QALY at any point in a conversation about what will and will not be covered in Oregon. And so we are asking Oregon to not waive that. We're also asking CMS, please do not allow Oregon in their process of deciding what is on the prioritized list. Do not allow them to reference QALY in any way. The second issue relates specifically to children. And there is a part of the Medicaid law that's called Early Periodic Screening, Diagnosis, and Treatment, EPSDT. And what it says is that Medicaid programs should be covering treatment, screening, and treatment for ages 0 to 21 that are medically necessary. And this is specifically understanding that if we treat many conditions when a person is first diagnosed, often in early childhood, we can maximize their independence and self-determination. And there's a value to that. So when the law passed, there was an acknowledgement that we may want to cover more and do more intervention for children because in the span of their life, it will have significant benefit, both to the individual, but also to society, because that person hopefully will have the ability to maximize their independence. Oregon chose to ask for a waiver from that federal requirement and said, we want to apply that prioritized list we have to children as well. So in Oregon, ages 1 and up, the prioritized list is put in place instead of that broader definition in federal law, which is what is medically necessary. So even if something is medically necessary for a child, their doctor thinks that, experts show that, we could show if we did this intervention, it would have significant improvement for their life trajectory, their level of independence and self-determination. Again, because it's a prioritized list, if it fell below the list, there is no appeal. It doesn't matter if it's medically necessary in Oregon. And where this has come up repeatedly is many conditions, one might say, I understand how it may have gotten that score. We don't agree with it, but it may have gotten a score in an adult population, but it's really very different for children. No, we don't even differentiate in how we score within an adult to child population. Also, if a condition is rare and therefore never got scored, it's either new or so few people in Oregon have gotten that diagnosis that our committee that scores these and puts it on the list hasn't even discussed it, it is automatically not covered. So if you are a person who has a child who gets diagnosed with a very rare medical condition, it is quite possible that it hasn't even ever been discussed, and therefore it is not covered. And that would not be true in private insurance that, again, goes off this medical necessity. And if they were to deny coverage, you would, in Oregon, have an appeals process through our insurance commissioner. So we are asking the federal government to say, no, do not allow Oregon to waive this EPSDT federal requirement. There should not be a prioritized list for children up to age 21.
So what I'm hearing, there's a lack of, Oregon obviously was feeling the heat about using QALYs and now is sort of being subtle about it. And then, or, maybe not so subtle. And then on top of that, the use of the quality is just, I mean, the impact just sounds like it's exacerbated for children because you have this added EPSDT waiver. I mean, am I correct? Oregon's the only state in the nation that has that. Is that correct?
That I know of, yes.
Wow. Okay. So Jen, I'm curious because in Massachusetts, I was reading your Boston Globe opinion piece recently, which was so well done. And I'm curious, if you could just talk a little bit about, and having gone, I mean, I can't imagine, because as a parent, you see your child succeed on therapy in a clinical trial, and then you're in a state where they're saying, oh, no, but we're not going to cover it, even though you have proof you have proof that it works firsthand. I want, can you just share a little bit about that, and then share, what that then means in terms of your advocacy in the state? Because I know the state's also been looking at a potential quality ban. Maybe you could talk a little bit about.
Yeah, I mean, I think that, it's devastating, and, we could go way deeper than my kids, right? It's kind of threatening innovation. It's specifically targeting drugs that are approved specific for the rare disease community via accelerated approvals and others. Some of these bans or these qualities reports, like the Duchenne one, they mention a lack of data, right? And so those are specifically targeting those drugs that are created and approved based on accelerated approval for the most vulnerable populations. As you mentioned, there is a bill 201 for a full quality ban in Massachusetts. I will say that advocating in Massachusetts, again, I'm a pretty well-connected human being. Advocating is cumbersome. I did register to speak and testify. I had to submit my testimony in writing because my registration somehow was lost, and so we countered that with an op-ed in the Globe. I also serve on the state rare disease advisory committee, so that we are heavily engaged in these topics. So I'm really hoping to be able to weigh in. I think that the major issue, again, comes back to transparency. I don't know that that the general public understands what our Health Policy Commission is, our HPC. We haven't had time to touch on that. And I know that we're running a little behind, but the HPC is formed in Massachusetts to make recommendations to the DUR. And those recommendations are going to be based on qualities, and they're going to be based on ICER reports. In fact, there is an actual contract between HPC and ICER. And so folks don't know that. So how do they lobby against it? There can't be a broad opposition because advocates are blinded to it. And so a lot of what I try to do is introduce folks to this topic. And when you do talk to the folks at HPC, again, they see disconnect between what they're doing, crunching numbers, and how those numbers and recommendations actually impact folks in Massachusetts, patients that they're talking about. The whole job of HPC and of Medicaid, every Medicaid, is to preserve money and valuable state budgets and make sure that they're, saving those spends. They don't have a lot of money, but denying life-saving medication for disabled individuals should not be, kind of that first look or first step.
That's really helpful. I'm hearing a lot about just understanding and knowing and transparency of the evidence base and need for better engagement strategies. I know we are running out of time, but I have one more question that I hope we can end on, and that is, because we all were watching Andre Gallegos and his presentation about qualities, and I hope that, what would you say to Congress about this? NCD is advocating, obviously, for kind of just an unambiguous, as they say, quality ban. What do you want? What would you say to your members?
Are you going with Meghan first?
I'll go first. I think what we're communicating is we are not against innovation. We are not against having to look at cost effectiveness in some ways, but it's when we try to quantify or numerate a concept that is by definition not definable in order to make these decisions. And the people doing that are known to be biased against people with disabilities. I mean, I don't need to tell this community that the healthcare profession has a bias that defines somebody's worth by how healthy their body works, which to me is mind-blowing. I have probably not had more health problems until now in my life. I have a chronic condition. I experience disability, and yet I am probably the highest functioning, greatest contributing I've ever been. So this idea that we're going to put a number that is a multiplier in deciding who gets treated, what is worth the cost, and that number is going to be presented as if it's evidence-based or as if it is not biased. And then we're going to make our decisions around treatment based on that is fundamentally discriminatory. And so what I am hoping the federal government will do is say, as we engage in hard conversations about the care that we are going to be providing, we need to do that while being honest with what these metrics are telling us. And we need to make decisions, and we need to be transparent about making those decisions based on what is objectively, factually accurate, and not based on our perceived perceptions of the quality of someone's life. That is not an acceptable multiplier. It's not an acceptable data point to be considered. There are hard decisions that have to be made. There is a finite resource of money that is put into place. And so we don't expect that there aren't going to be hard choices. We don't expect that they won't look at cost effectiveness, but it has to be done in a way that is unbiased, that does not discriminate against people with disabilities, and looks at how bias has played in to health inequities today. You know, I look a lot about, yes, people with disabilities are clearly impacted by scores like QALYs, but so are people of color, because they have experienced poorer quality healthcare that has resulted in poorer health outcomes. And because they've experienced that systemic racism in healthcare, they have lower life expectancies. And therefore, when we multiply treatments, when we look at treatments that impact people and how effective they are, the number of years of life that they're going to benefit from a treatment is lower because they have suffered chronic discrimination, and we're perpetuating that. So these are hard conversations, they're highly technical, but it really requires a level of openness and transparency and debate about what is bias and how do we remove our preconceived notions about quality and about the value of life from those hard conversations. So that's what Congress should do. Good luck. But when in doubt, ban anything that is judging quality of life.
Jenn?
Sure. I mean, you said it very well, Megan, and I was going to take it back to the people too. I think that that's our job as patient advocates. And so let's bring it back to the human beings that these policies actually affect, which in my life are my adult sons, who arguably my oldest son, who's 23, is a much more productive human being than I ever was. He's a co-founder of a nonprofit for young adults. He's a public speaker. He's an activist and an advocate. He's going to school for mechanical engineering and biomedical engineering. He is an independent human being with a lot of intelligence, and he's also kind of a funny, cute kid. And they're living in their apartments. They, because they've had access to drugs through clinical trials, they live in an apartment. I don't see them every day, which is phenomenal because these guys are living lives as independent adults living in wheelchairs, despite the fact that they have incurable and terminal illness. So I would challenge anybody that is a decision maker to think about these people as kind of those throwaway kinds of people, and really think about them as human beings that want to live their best lives for as long as they have a life. So it's about quality and not quantity. And then finally, in the words of one of my heroes, and Dr. Janet Woodcock is my hero, she has said to me, we've had conversations about this issue, and she has said, when you are looking to make budget cuts, do not start with access to innovative therapies for chronically ill people. So we all recognize that there's a problem, but I like to repeat that line often, said with anger and said with encouragement as well.
You guys are awesome. Thank you so much for being here today. I know we're running a little bit late. I hope everybody can stick with us.